So I'll introduce our speaker today, Erika Cathey. So Erika is the Communicable Disease and Emergency Preparedness and Response Manager for Larimer County. Let me know if I got that wrong, Erika. It's quite a mouthful, but that's a big title. There's I think a lot that goes into it, and she's going to tell us today kind of about the public health side of vector-borne diseases, and then I think also other types of communicable diseases as well, and going a little bit into her background, which I mentioned in the email just from LinkedIn. She started in the Navy and has gone through kind of various public health and private industry kind of path, it seems like. So she'll tell you more about that. Without further ado, take it away, Erika.
Thanks, Dr. Burton, and thanks for having me. I'm super excited to chat with you all. I recognize some familiar faces from CSU, and I'm really excited to share. We're kind of right in the middle of our vector-borne disease season, so it's an exciting time. And I'm going to share my slides to make sure you can see them here. Yeah, can you all see my slides? Okay, thanks, Tim. So I'll share with you a little bit about local public health response, like Dr. Burton mentioned, just kind of the plethora of diseases that we deal with, vector-borne disease being one of those categories. And then I'll share a little bit about just quickly here, and I think I have a couple of my staff and interns on the call that joined. They know I'm kind of long-winded, like Chatty Cathy goes along with the name. So, but I became interested in public health after majoring in anthropology. Do we have any? I just want to, like, a show of hands, like how many folks majored in like laboratory sciences, micro, or in that field right now? Oh, yeah, Tim. Okay, awesome. How many people, and if you're not on camera, that's fine too. If you want to use the little hand icon, that works. But anybody come from social science background? No? Maybe some folks. Well, I think the coolest thing about public health is that we have such a variety of backgrounds and undergrad degrees that feed into MPH programs, and then we get to benefit from all of that variety in public health. And so I majored in anthropology. I heard about a really cool, oh, sorry, I shouldn't say cool. It's a neat disease, a prion disease that is called Kuru, and was really focusing on cultural anthropology. So it's a really neat story about an anthropologist that went to live with a tribe in Papua New Guinea and observed that they had high rates of this Kuru disease, had to live amongst them to understand that they were participating in a ritual where they would consume their deceased family members' brain tissue as part of honoring them. And so I just thought that interplay between culture and disease transmission was so interesting. And that's why I decided to go into the MPH program. And so from there, I kind of had a foray into vector-borne disease because I lived in Florida, which there's a lot of different vector-borne diseases down there than what we have up here in Colorado. A lot that require a lot more public health effort on the back end to address than West Nile does. And I had landed that fellowship with, it's called the Florida Epidemic Intelligence Service. So it's modeled after the CDC's Epidemic Intelligence Service, but more for MPH students who had just graduated. So if you're interested, I'll put a little plug in because it's a really great program. California has it, Florida has it. Not that we don't want to keep you all in Colorado, but it's a 2-year fellowship really focused on field epidemiology. And so it was right in the midst of Zika in 2014. I also had Ebola, that scare in West Africa at the time. And so I'll talk a little bit about the differences between West Nile and vector-borne disease response from the public health standpoint up here in Colorado versus what we did in Florida, because there's a pretty big difference in the amount of effort required. And so here I am in Colorado. We're in the middle of vector-borne season, like I mentioned. We just had our first positive pools for West Nile a few weeks ago, and we're also in the middle of a pretty cool project aimed at changing the town of Berthoud's current policy on when to spray for mosquitoes that I'll share, that is a cool pilot, and really kind of shows you the impact that public health can have on policy, which is where we know we get a lot of the biggest bang for a buck in terms of preventing disease. That's a little bit about me, and how I got here, and I'll include some stories as we go that I think you might find interesting. But first, I'll just quickly overview. I know you all have had other presenters. I know you know have received a lot of information probably about the basics of West Nile virus. So I'm not going to go into that today. I'm just going to talk briefly about what we observe, the epidemiology of West Nile virus in Larimer County, and then what the role is of public health in addressing West Nile virus. You'll see there's a lot of variety in our county in terms of how West Nile virus is addressed and controlled. Many of you might have seen this graph. So this just shows, that Larimer County is kind of a hot spot in the West. We're number 299th, which doesn't sound very high, but we're a smaller county compared to places like Maricopa County in Arizona, and we do see a lot of neuroinvasive West Nile. And we do know that 80% of West Nile human infections are asymptomatic, so you can extrapolate that these neuroinvasive diseases where people have really severe infections are really just the tip of the iceberg of what we actually have in terms of West Nile virus infections. This is a little, this picture here from State's web. It's not a rate, right? So it's pure case counts. And so we look very bad up here in Larimer County. And this is primarily because of the 2003 outbreak we had when West Nile virus was first introduced in Colorado. And so you can see down here, I highlighted our 546 cases in 2003. And we had 66 deaths in the state that year, which is really high. We typically have less than 10, but that was because it was a new disease and people had never experienced it here before. And so this graph still kind of tells that story of back in 2003, we were hit really hard. And that's why such an intensive effort to prevent West Nile has been rolled out here in Larimer County, particularly in the city of Fort Collins. So how many of you have you heard that last year was a historically bad West Nile virus season? Okay, so this graph just kind of shows that we had a really bad season last year. We had 52 human cases reported just in Larimer County, and typically our 10-year median is 18. So really high number of cases reported last year. The percentage of deaths that we saw was pretty typical, about 5%. A third were neuroinvasive cases, meaning they had really severe, sometimes encephalitis or meningitis caused by West Nile virus. And we typically see cases between the ages of 55 and 65, a median of 56. We don't know if that's just because of exposures, people are outside more, or we know that it's probably likely part of the fact that your immune system kind of weakens after age 50 and starts to decline. But we do have a really high percentage of males being infected, and that could be occupation, it could be time outdoors. It's something interesting that we keep an eye on, but we don't have a great answer for. And we do see that trend pretty much year to year. One thing that I'm not a conspiracy theorist or anything, but it is interesting that 2003 was a terrible year. That was our outbreak year. 2013 was a terrible year. And then 2023 was a terrible year. So every 10 years, we seem to have this huge influx of human cases. And any thoughts on factors that might play into that? You can throw it out there or put it in the chat. Thanks.
That might be like the minimum amount of time for immigrating in populations of people from across the country that there's enough immunosusceptible people that there's just a huge resurgence.
Could be. Yeah, that's a great thought.
Hi,
Definitely.
Erica. I have another thought.
Yeah.
Precipitation patterns, like weather increasing higher amounts of water, and standing water.
Yeah, that could definitely be too. Certainly, the climate factors are big, and immunity was the two that I was hoping to hear. Any others? Oh, great thoughts. Yeah, it's a puzzle. We don't quite know. It's probably a combination of factors, and we also, it's likely also that going back to this picture here of Larimer looking pretty dark there. We don't know, and I'll go into West Nile virus human case reporting that we investigate, and there's also bias, right? So people in Larimer County are acutely aware of West Nile virus because we've had terrible years. They may be more inclined to seek care, and testing for West Nile virus results in more human cases being reported to the health department. So there's all those factors, human behavior factors also. But I'm going to switch a little bit. Any questions up to this point? And thanks for putting the application in the chat for EIS. That's awesome, Tim. Okay, I'm going to switch gears a little bit and just talk about communicable disease reporting in general. And this will help to kind of show you how we get West Nile virus human cases reported to us in the process for investigating those. And it goes along with a lot of other diseases that we deal with, like vaccine preventable diseases, enteric diseases, so your hoop diseases, we call them. And so essentially, has anybody heard of communicable disease reporting laws? Does anybody work in field or medical or where you've heard that this is a law? Okay, cool. Well, this will be good then. I think I don't think a lot of people know this, that there are about 100, and they're adding more diseases that are reportable, which means that any doctor who diagnoses a disease that's on this list, and I have a little snippet down here, there's, like I said, over 100. If any doctor diagnoses that in a patient or a laboratory detects a pathogen that's on this list, they're required by statute, so under law, to report it to the health department for investigation. Important to note that this often occurs in the background, so the patient is not aware that these results are being sent to the health department. We don't have to get patient consent for that. It's a law. So often laboratories in particular will automatically transmit their electronic laboratory data to the health department system, to our statewide system, and then that's how we are notified. Sometimes we're even notified quickly before the provider is notified. So I'll talk through our investigation process and how we kind of loop that all together, make sure we're not calling patients, cold calling them, surprising them when their provider hasn't had a chance to talk to them about their diagnosis. But you can see a couple of these. We got measles on here, anthrax. Every disease has a different reporting requirement. So like something like measles, a provider is required to report to us upon suspicion. So they don't even have to have a lab result. They just have to have a patient that they are saying they have a rash, they have a fever, they look like measles, they're unvaccinated potentially, and we need to report it to the health department immediately so that we can get on that investigation quickly. So just pointing out here that you might, I know you have CDC next door, and you've heard of the state health department, maybe CDPHE or the Colorado Department of Health and Environment. Most local agencies, so the Larimer County Department of Health primarily leads investigations of reportable diseases among our residents of Larimer County. And we report that data to the state health department, so the Colorado Department of Health. And then Colorado Department of Health reports that information to CDC. And that's where we get all of our beautiful statistics that we get to work with, that you all might be working with in your public health careers. So one thing to note, especially when we talk about West Nile, is that cases are reported and investigated by their county of residence. So if you're a Larimer County resident and you travel to Texas and you get bitten by a mosquito and you contract West Nile virus, you're going to be contacted by the Larimer County Department of Health and Environment and asked a series of questions. And then you will be reported on a map, not you, but your data. Okay, your case count will be reported on a map in Larimer County of Larimer County West Nile virus cases. So that's a big limitation, right? That is not ideal. We would love to be able to investigate folks by where they were exposed, but it's really difficult to ask someone to recount where they were bitten by a particular mosquito, right? So sometimes we can figure out, I traveled to Maricopa County this week, and then 2 weeks later, I developed symptoms of West Nile, and you can put it together and say they were likely exposed from Maricopa County, but the way data is tracked and reported, they're still going to default to Larimer County. Does that make sense? Okay, and that's all reportable diseases. So just take that into consideration when you're looking at a case count map or a rate map of diseases and where they're reported. Just know that that's where the person lives. Okay, so how do we get notified of West Nile virus cases or any case of a reportable communicable disease? Essentially, it starts with the doctor's office. Provider suspects West Nile or measles or whatever the case may be, and maybe they order a lab test to confirm it. That, like I mentioned, that lab test, if it's positive, will be electronically transmitted to the health department for investigation. West Nile do receive reports from blood donation sites. So folks that go to donate blood, their blood is screened for West Nile virus PCR, and that is also reported to us. And often those people, we call them and we inquire about whether they had any symptoms, and maybe they didn't, or maybe they did. And if they do have symptoms, like a fever, then we'll investigate them as a West Nile case. These are the type of labs we get. So I know we've got a lot of lab folks in here, but you all probably know this. IgM antibodies associated with acute infections. IgG antibodies are more the long-term antibodies that could indicate a previous infection. And then we've got our PCR or NAT testing, that's molecular testing. And then we can have culture, which we rarely ever get. We usually will get IgM antibodies indicating someone has been recently infected. And then I won't belabor this. It's a lot of words on the next few slides, but I just want to show you all that that really the investigative part of our job comes in where you have a lab result. Labs have to be correlated with epidemiology to make sense and to make a case. So you may get lab results, there's false positives. So we really have to take a look at the lab that we get and apply it to these nationally established case definitions. And we have to have some correlation between the individual symptoms and the lab result to count it as a case, which is important for statistics, right? That we're all consistent in how we're counting our cases. So like I said, a lot of words here, but basically showing that this is the clinical criteria that we have to investigate. So in public health locally, we have access to most electronic medical record systems. So UC Health, Banner, a couple of our federally qualified health centers, and Coreo, which takes all of the health records from various systems and puts them in one nice place. And so what we do is we go and we search the person's medical record, and we do a medical record review and try to identify what kind of symptoms they had, what their onset of illness was, and see if they meet this criteria. So did they have a fever? Was there a diagnosis that was being considered that seems more likely? And then did they have the compatible symptoms? And then they're classified, of course, by neuroinvasive, which is the severe manifestation of West Nile virus, versus non-neuroinvasive, which is the majority of the cases, people just have a fever and maybe a headache and maybe a rash, and then they go get tested and they're positive for West Nile. And so we have to pair that with the laboratory criteria. So did they have an IgM antibody, which is a common lab that we see. It's obviously not as reliable as like a PCR would be. So we classify cases into confirmed and probable. Have you all heard these confirmed, probable, suspect cases in your epi classes? Yeah, so that's kind of how that works. It's basically the strength of the lab, and then compatible symptoms results in confirmed, probable. If it's a lab that is not very reliable, or the person has a very vague symptom, they might be classified as suspect. And so that's how cases are counted. And then oftentimes we do call providers and say, you know, can you tell me a little bit about how this person's symptoms looked? Oftentimes we'll have to get clarification on whether they had a symptom or not. Maybe it wasn't documented. And then we'll classify them like confirmed or probable here. So they have to have lab criteria and clinical criteria to be considered a case. We do know that we probably missed some cases because one of the criteria for West Nile is you have to have a fever. And we know not everybody has a fever, but that is to ensure standardization in counting cases. So we want to say you must have a fever. So we probably do miss some cases and are undercounting. And we know cases are underreported anyway, because how many of you go to the doctor every single time you have a fever? Yeah, no, most people just manage it at home. And so we know that cases are significantly underreported. So once we get, like I mentioned, we go through medical record review, we consult the provider, sometimes infectious disease, and then we talk to the person. So this is the fun part. When you really get to interact with the public, well, they're really funny and really entertaining and interesting when you call them, because you're basically cold calling someone. And what we'll try to do is contact the provider and say, hey, have you talked to the patient about their lab? Yes. Okay, great. Could you please let them know that the health department will be calling them? Because I don't know about you all, but it's kind of scary when you get a call from the government inquiring about your health information. Most people assume that the health department's calling them because they have an STI, and that causes a lot of panic, like a sexually transmitted disease, because a lot of people think of, if the health department's calling me, I either have HIV or I have an STD. And so immediately, you know, a big part of our job is gaining trust, and immediately over the phone, which is difficult, right? Cold calling someone, immediately gaining their trust, explaining to them why you as a government employee have their lab results, which is always a fun conversation. And then quickly asking them for information, right? So you're trying to get data from them basically after building rapport within a few minutes. And we do get a lot of hangups, but not many. Most people are intrigued enough and want to participate for the benefit of society, which is really great. Any questions about that? I should have set up a mock interview. Our staff will sometimes give each other a hard time as a patient, you know, on the phone, because it's helpful to test that out and see how you react and how quickly you can try to talk someone down or build their trust in this kind of unusual situation.
I have a question.
Yeah, hi,
It's
Anna.
Anna. Hi, Erika. How does that kind of like transfer of information like interact with HIPAA laws and patient privacy laws? Just kind of curious. And like, do people ever say like, why do you have this information? This is my private health information.
Yes, great question. All the time. So public health is exempt from HIPAA, which means that we can receive health information for an individual without their consent, right? So that information, once we do receive it, we are obligated under HIPAA to protect it, but we are not obligated in like the way that if someone's requesting their med to sign a form that says I release this information, all that is public health is exempt from that because of the urgency of disease investigations. So I have a spiel. I'll share my spiel with you as if I was calling you on the phone. What I typically say is, hello, my name is Erika. I'm calling from the Larimer County Department of Health and Environment. I'm calling regarding some lab results that I received from insert provider's name. So the person knows that I am part of their medical care and not some government entity who has their medical information just for some random reason, right? They think I'm, or understand that we're part of their continuity of care. And that I am calling because your provider reported these labs to us because it's required under public health law that public health be notified of certain reportable diseases and conditions that could be causes of outbreaks. And that is so we can confidentially investigate this with you and understand and make sure the public isn't at risk. So something like that, that just kind of explains immediately why we have their information, what we plan to do with it, and help them understand that we are doing something for the public good and we really need their help. And so most people are okay with it after that. We do, during COVID, things got pretty tense and people got pretty angry. But in general, I think that's kind of died down and people are a bit more understanding. And so from there, we'll kind of mention, I'd like to ask you a few questions to better understand where you may have been exposed. This can get a little messy with diseases other than West Nile. West Nile is pretty straightforward. We are calling to obtain information to help understand West Nile virus trends. In other cases, we're calling to prevent further infection. So for instance, if you go to the doctor and you have salmonella, that report's going to be reported to the health department. I'm going to call you. I'm going to tell you, about salmonella or answer your questions. And then I'm going to ask you where you work and what you do and if you volunteer. And I'm assessing whether you're putting the public at risk through your occupation for further spread of salmonella. So for instance, if we have restaurant workers or folks that work in childcare or folks that work in a long-term care facility with vulnerable residents and they have salmonella, we are going to ask them to submit 2 stool cultures through our state public health lab, and those have to be negative before they can return to work. And that doesn't always go well, as you can imagine. People don't all have paid sick leave, and we're asking them to stay home from work unpaid. And we do have resources we offer them, but we can't pay them, right? So it gets really tricky. It's really tough. And especially from an equity standpoint, we often encounter folks that maybe have frontline worker jobs, low paying jobs that don't have sick leave, and they often are forced to stay home and choose between staying home and going to work sick, which is really unfortunate. And so we do our best to help them out and get them back to work as quickly as possible. So jumping back a little bit to West Nile, we ask them if they know where they were exposed. That's helpful information for us to document, but often people don't. They might have an idea and we'll list out a couple potential exposure places, but it's really hard to track down. Most people just say, well, I generally spend time outside or I generally do gardening, and so we'll document that. But we're also asking them about sequela or any symptoms they've developed after as a result, or conditions they've developed as a result of West Nile, for tracking and understanding West Nile. We're also asking if they had donated any blood or received any organs, because West Nile virus could be transmitted that way. So we want to make sure if they have, that they don't donate blood basically for, I believe it's 90 days after they're infected, so that we don't get that in our blood supply. although they do test and screen for it, just in case. And then pregnancy status. This was obviously a big thing during Zika, not as much during West Nile, but it's still important to capture from a data standpoint, so we understand if things are changing and, you know, West Nile virus is being transmitted to babies from infected mothers. So a lot of this is just more for research purposes. And then travel history, because we want to know how often folks are being infected while they're in our state versus if they travel to a country that has West Nile. It's important to know how many of our cases are acquired locally versus internationally, so we can determine if those trends are changing or we're seeing increased introductions of certain diseases in our areas. Okay, on time. Okay. Okay, so to talk a little bit about public health response, I kind of say West Nile virus is one of the easier diseases from a public health standpoint to work with when it comes to other vector-borne diseases that are a little bit more challenging, especially in Florida. With West Nile virus, with humans being dead-end hosts, and I know this picture is way overused, but I just wanted to show that, you know, humans are dead-end hosts for West Nile virus. So a human that's infected and viremic cannot, you know, a mosquito cannot land on that human and suck up their blood and then go to another human and transmit West Nile virus. We are very fortunate that that does not happen. That is not the case for other diseases like dengue, chikungunya, Zika. A human can bite a viremic human and take that virus and bite another human and infect that human. So you can understand how our response to West Nile is quite different than these other diseases, because we are focusing with West Nile on collecting data to understand West Nile and controlling it. We are actually more involved in preventing the spread of diseases from human to human through mosquito vectors with these other diseases. So for instance, when we have a case of West Nile in the county, we go through the process, we collect the data like I showed you, and that's pretty much where our human investigation ends. If we have a case reported of dengue fever in Florida, we would not only do the investigation to call them, collect the data, we would work with mosquito control to go spray a perimeter around that individual's home so that their mosquitoes can't pick it up from them and give it to someone else. We'd ask them to isolate for 14 days, I believe. Maybe, sorry, 7 to 10, I think, for dengue. So they can't go anywhere, can't go to work, because we can't risk a mosquito picking it up from them and then gaining a foothold in our county, which now, unfortunately, since I left Florida, dengue has and is now locally transmitted in Florida. So the mosquitoes won. They were able to pick it up from enough humans and transmit it, where before it was just brought in from international travelers. Now, probably also some climate change, they've really gotten a foothold, and now it is an endemic disease down in Florida, which is really scary. And so that's the difference. We go door to door in these cases. After we spray the perimeter around their home, we go door to door, do an environmental assessment, talk to people about bird baths and how they're breeding grounds for mosquitoes, knock over flower pots. It's pretty intense and a lot of manpower and field work. So we don't have that here, but we may someday. So I'm just going to share a little bit about on the other side. So aside from human investigations of West Nile, we do work with all the county, all the towns and municipalities in our county on their West Nile virus policy. And so I'm sure you've heard this from the other speakers about integrated mosquito management and control. And so that usually consists of some surveillance and mosquito testing, reducing sources, standing bodies of water, mosquito breeding grounds, controlling mosquitoes at all life stages, larvae, pupae, adults, public education. So that's a big part of what we do. And then kind of evaluating the policies all the time, because things change and environmental factors change and mosquitoes change. And so we're really working with these municipalities with the resources that they have to implement what's best for them. So we don't get to tell all the municipalities like Berthoud and Loveland and Fort Collins and Wellington how to do mosquito control in public health. We can give them kind of the best practices and let them decide based on what resources they have. We have big towns, small towns, everybody's got different amounts of money and different resources staffing wise to do this. So it's their decision. And then we work with them to try to give them the best policy they can get. So a lot of them do it very differently. Ecological restoration, introducing predator species. We have larvicide applications, adulticide spraying, so mosquito spraying, usually from trucks, and then public education. And so we're constantly consulting with these different decision makers on what policy would work best for them. This slide, so this is kind of cool. One of our interns did a study on or a policy scan for the county. And so he was looking at how does each one decide when to do an adulticide spray? And you can just see the variety in our county, just our little county. We have Fort Collins. They spray if the vector index is equal to or greater than 0.75. Loveland sprays all over the place. I mean, they just spray based on abundance. Berthoud has a vector index of 0.75 for greater than 2 consecutive weeks. And then some have a combination of abundance plus a proportion or QLEX. And then some just spray because people are complaining. So nuisance complaints. Wellington's one of those that if they get enough complaints from the public on the phone, they spray. And then Estes Park doesn't do anything. And then we also have HOAs and private Mosquito Joe companies that go and spray. And so there's just so much variety they choose to do. Is anyone aware of the Berthoud, kind of what happened with Berthoud last year? Okay. So I'll tell you a cool project real quick that we're doing with Berthoud. So obviously they have a vector index of 0.75 for 2 consecutive weeks. And just so we're all on the same page, a vector index is a combination of abundance and infection. And Tim could probably, I might butcher this a little bit, and infected female QLEX mosquitoes for West Nile virus. And if you're at 0.5, which is the level the county says you should spray to prevent human cases, because we start to see human cases when the vector index reaches 0.75. When you get to 1.0, human cases are clearly correlated with a vector index of 1.0, and you can expect to see human cases 2 weeks later. So it's a really nice warning and indicator for municipalities to use to get ahead of those human cases and spray when their vector index starts creeping up around 0.5. We do not like this policy clearly because it's supposed to be an early warning indicator. And this is a very reactive kind of way to use the vector index where we say, we got to have 0.75 for 2 consecutive weeks. Well, we're already way behind the curve in terms of preventing human cases. And so last season, the town of Berthoud was concerned because they had 5 mosquito traps and the vector index was kind of bouncing all over the place. And so we worked with CDC and CSU, you all, and Dr. Ebel to acquire 5 additional traps so we could increase the number of traps that they had and hope that that would kind of stabilize the vector index week to week, and it could be a more trustworthy indicator for them to use. And we're already seeing the benefits of that. We already see that the confidence, which we assumed, but Toby at Dr. Ebel's lab there has done some nice visualizations to show that, you know, the more traps you have, the greater your confidence is in the vector index. Your confidence intervals are tighter, and you can make a better decision, right? With more data is basically the story. We've also only had positive mosquito pools in the traps we added from CDC. So none of their existing traps were capturing West Nile. All of the new traps we added have captured West Nile, which is kind of nice for our pilot. But we're hoping they will keep them after this summer trial. It didn't help that we had somebody report that one of our mosquito traps was a bomb. And actually the bomb squad had to go out and was x-raying the trap, and I got a sheriff's dispatch call that we needed to visually confirm that this was a mosquito trap. And unfortunately, they did not hang it back up on the tree, so we didn't have any data for that week, and it really messed up our data for Toby's weekly report. But overall, I think they will be receptive to the idea and will keep the traps to help prevent West Nile in their residents. I'm hopeful. I'll just finish up here, and then I think we have some time for questions if that works for you, Tim. But future considerations, I think one cool thing that we would love to involve CSU students in, that we have been talking about with Dr. Ebel and the One Health Institute at CSU, is doing what's called a CASPER. Has anybody heard of a CASPER? No. Well, it's pretty cool. It's called a Community Assessment for Public Health Emergency Response is the acronym. And it's basically a CDC methodology that allows you to identify, I think it's 30 census tracts, and you basically do a door-to-door survey of every 7th house. And so what we would be asking folks is information, and Dr. Kelp's done a lot of this work too. So we're going to loop her in on, she's done a lot of West Nile virus perception work and communication work. And so asking people what their perceptions are around the use of adulticide in particular. And the goal would be to be able to generalize what Larimer County residents, how they feel about the use of adulticide, and be able to provide that to decision makers, because all the decision makers here are kind of objections to the use of adulticide from the loudest voices, right? So in Berthoud, the use of adulticide brought up a lot of community concerns. People mentioned, that they were trading West Nile virus for cancer. It was pretty intense debate, and not a lot of it was scientifically backed as far as hazards associated with the use of adulticide. And so we really want to get at that information and be able to say, aside from those loud voices that you might hear that are opposed to mosquito spraying, it is a valuable tool in our toolbox. We use it judiciously. And here's how people feel about it, or here are their concerns, and maybe we can address those more proactively and say, listen, it's an ultra low volume mist, it's only sprayed at night. Kind of just kind of assist in providing data for that debate, because a lot of it is based on feelings and maybe some bad experiences that people have had. So yeah, that's in the works. It would be a massive effort that would require a lot of students to help us go door to door and ask people these questions and gather some really helpful data. So I'm putting a plug out there. I think there might even be a course that's going to be designed around it, and talking to some of the public health professors over there. So keep an eye out. It should be really fun and really important for us to actually provide information to decision makers about when we should spray and when we should not. Insecticide resistance concerns are always on the forefront, I think, especially with the variety you saw in all the different ways that people are deciding to those, and the HOAs that, there's kind of this overlap of private companies spraying and the counties or the municipalities spraying. And so that's always a concern. I know CDC provides insecticide resistance kits, and I know, Tim, you showed us some cool ones when we came to visit your lab that your team's doing. So, and then lastly, just kind of the impact of climate change. This is a really concerning topic right now. I know, just with, like I mentioned, just the local locally acquired dengue outbreak in Florida, super concerning. The malaria in Texas and Florida, that should not be happening if good public health work is going on and we're addressing the fact that vectors are changing their areas that they're present in. We just added Chagas disease to the Colorado reportables list, which is a really nasty bug from kissing bugs that people get, and it's more common in South America, and we never really had to deal with it up here, but now we're prepping for having to deal with that. And Lyme, kind of closing in on us. So yeah, it's scary stuff. We gotta use the One Health approach to get ahead of that. And so we're working actively with lots of folks in that arena to try to get ahead of ensuring that we don't have new vectors coming to our state, stopping them if they do, keeping them from gaining a foothold as far as disease in humans that we have to worry about up here. So I think that's all I had. Was there anything else, Tim, that you wanted me to talk about that I didn't get to?
No, I think that was great.
Okay.
Yeah. I'm just trying to find out about that course. I think it'll be in a later email. I can send out some information to everybody. I don't have it in my email right now, but I was just, yeah. There's a few others that are there that I'll also send out that are kind of not necessarily that Casper survey, but maybe are. So I'm just trying to get to the bottom of that, and I'll follow up in a little bit.
There's also a great infectious disease. Sorry, I can't remember what it's the title, but it's focused on equity in infectious disease. And so that's going to be a really cool one I saw this fall. Happy to take any questions though. Thanks for listening to me drone on. Kind of long-winded.
I see Alex put one in the chat, Erika.
Okay, let's see. So, hello, Alex. An individual is very against following the Delta Guard. Yeah, that's a great question. We typically, I don't know specifically about Delta Guard. However, I know we typically work very closely with Vector Disease Control International up here. And so we'll usually share their materials or talk about the ultra low volume mist and what we do to minimize the risk to pollinators, such as waiting for the little bumblebees to go into their homes and spray at night or in the evening when they're in their hives. So that's kind of our main talking point around that, is that there's not no risk to animals, but we can minimize the risk by doing it only when we have good data to support spraying. And the city of Fort Collins has really been a leader in that, I think, with just how they approach the vector index. So they used to spray an entire quadrant of the city. They had it initially divided into quadrants. And so if they had a vector index above 0.75, they would go spray the entire quadrant. Now they've reduced that. So where every week, every single Monday, we meet with the city of Fort Collins on a call, and we'll calculate a vector index based on a floating zone of 5 traps. So you can really narrow down the amount or the area that you're spraying. And so I think when people hear that we're balancing, the use of good data, minimizing any potential risk to our pollinators, that usually that kind of helps, I think. Did that answer your question? Ooh, that's a good one. I'd have to look back on malaria. Dengue, I knew, is a very recent development here in the United States. Even when I was in Florida 10 years ago, we had no dengue locally acquired. So it was all people that had traveled from countries where dengue is present and brought it to the United States that we investigated. And now, like I mentioned, unfortunately, it's established a foothold in Florida and will likely be transmitted where, where we find folks that didn't travel anywhere and they got dengue fever here in our country. And that's something we really don't want to see, right? So good public health control of those diseases is essential to preventing further spread. And I don't see it coming to Colorado. We just don't have those vectors just yet, but that could change, right?
I can jump in a little bit and talk about malaria. So my background's in malaria. I'm not perfectly familiar with the history in the US, but my understanding is basically we used to have it in the South, Southeast, generally Florida, I guess. Florida, Georgia, Carolina, probably Alabama, that kind of, proper South. And my understanding is it was eliminated from the US basically through habitat like modification, so draining swamps essentially, and screening houses basically. So kind of permanent structural changes ended up kind of driving the vectors out. And I guess as is the trend in other diseases too, possibly maybe coming back with increased habitat ranges for certain mosquitoes and that kind of thing. But yeah, there was some other history too with like DDT spraying, and that was more, I think, less US centric. That might have been kind of the final push that the US needed to eliminate it here. But essentially in Africa, at least, DDT saw like a massive reduction and then a massive gain of resistance and then a complete reversal, and it came right back. So that's kind of the DDT insecticide resistance trend is something we're seeing again currently with malaria and other vector-borne diseases. But I don't specifically know how influential DDT was in America. I do know they sprayed it like crazy, so I imagine it was it was helpful in reducing malaria, like getting rid of it completely. But yeah, draining swamps and screened houses was a huge part of it. And I don't know enough to know like how bad it was when it was here. It might have only been here a little bit, as it were. If there's no more questions, I mean, we still have a few more minutes. So if you do have a question, feel free to jump in. If not, let me find this link. So we have a weekly survey we do. I have the link here. This is for the attendees, Erika. So for the RaHP VEC intern specifically. So it is here if you can take a few minutes to fill that out. I'll also follow up with an email to all of you with that link again, just in case you aren't able to copy it down now. But it takes a little bit of time for the Zoom recording to get processed and then for me to edit it a little bit and upload it. So that might not come until Monday. So here's the link for now. Otherwise, I will follow up in another email with that. And thank you again, Erika. That was great. It was really nice to hear kind of the other side of things. And yeah, and we do have a few minutes if anybody has any last minute questions.